Good morning, everyone, and welcome to our Grand Rounds presentation. I'm Michael Fiore, Emeritus Professor in the Department of Medicine, and I'm so honored to introduce this morning Dr. Hasmeena Kathuria. Dr. Kathuria completed her undergraduate education at Northwestern, medical school at Loyola, and in her internal medicine residency at Indiana University, where she also completed a chief medical residency. She then moved in the year 2000 to Boston and completed a fellowship in pulmonary and critical care medicine at Boston University Medical Center. And she also secured her certification in sleep medicine. In 2024, she moved to our university where she became, on July 1st of 2024, the director of the Center for Tobacco Research and Intervention. So I'd like to share some personal thoughts. In 1992, then Chancellor of the University of Wisconsin, Donna Shalala, asked me to serve as the first director of an envisioned center for tobacco research and intervention on our campus, with the goal of being a national resource for reducing tobacco use in America. The center, known as CTRI, has had a great run and has met the goals of leading tobacco cessation and control policy nationally. Most importantly, the center has brought together a remarkable team of collaborators who together have generated more than 500 peer-reviewed publications, secured 5 consecutive NIH center grants, and more than 30 NIH R1 grants, in total over $200 million in grant and programmatic funding. It's been an incredible privilege to lead the center as its founding director for 32 years. That finished up in July of 2024 when Dr. Kathuria took over as the second director of the center. After seeing Dr. Kathuria lead CTRI for the last year, I can say unequivocally that she is the perfect individual to direct CTRI. She has brought her gravitas as a nationally recognized clinician scientist with a highly impressive set of accomplishments in tobacco control. Most of all, I've been impressed by her highly effective collaborative leadership style, bringing together the 45 individuals of CTRI to work as an effective team to advance tobacco control science and practice. This has been particularly apparent over the last 4 months as we, along with the rest of the university, have faced the chaos and uncertainty at the federal level, the sort of disruption that could hamper even the best scientific leaders. With calmness and positivity, she has led our team and kept us focused on what we can do effectively and has led us to do so. She has also been remarkably successful in securing additional funding in only 10 months on the job. She has personally secured 3 grants, including a $10 million PCORI grant with multiple PI Megan Piper, and next week she will submit a $14 million NIH PO1 Center grant with multiple PI Danielle McCarthy. It is staggering that she's pulled all of this off in only 10 months. Finally, I want to say that her character as a leader is just extraordinary. She is thoughtful, kind, collaborative, and humble. CTRI is remarkably lucky to have Hasmeena Kathuria as its new director. And she, in my view, is the ideal leader of our center. Hasmeena, thank you for joining us. We look forward to your Grand Rounds presentation today.
Thank you so much, Mike Fiore. What a warm welcome it's been from all of you at UW and everyone at UW CTRI. So let's kick this off. I am going to focus on tobacco treatment. Since I'm reaching a clinical audience, I want to talk about effective interventions and particularly strategies to integrate tobacco treatment in clinical settings. I have no conflicts of interest to disclose. At the onset of this program, we're going to go through three major objectives. The first is comparing the different FDA-approved treatments for tobacco use disorder. There's only 7. We'll go through those and then talk about the most effective ways to introduce this pharmacotherapy into clinical settings. I'll then switch to talking about e-cigarettes and how they may pose a harm reduction strategy, but may also impose risk depending on the end status use of tobacco in these patients. So let's start with talking about some trends in smoking cigarettes. So as you can see here, the per capita consumption of tobacco use peaked in the 1960s and then has continued to decrease. This decrease has largely been due to effective policy and public health initiative, including in 1964, the first Surgeon General's report that linked smoking to poor health. In addition, we saw a rise in federal cigarette taxes. There was a master settlement agreement, as well as the Family Smoking Prevention and Tobacco Control Act in 2009. This Tobacco Control Act in 2009 was the first time that the FDA was authorized to regulate tobacco products. In addition to public health initiatives, the other major reason for a decrease in tobacco use has been the availability of effective medications. In 1996, nicotine replacement therapy first became available over the counter. 1 year later, bupropion, marketed as Zyban, was introduced specifically for smoking cessation. About a decade later, varenicline became available in the US market. And as you can see, in the past 20 years, there have not been any new medications available, although in 2021, the first generic version of Chantix was approved. In addition to these remarkable efforts, there have been 3 critical efforts led by Mike Fiore that have really impacted tobacco treatment. The first was in 1991, the proposal that tobacco use become one of the vital signs. This was critical because now at every clinical encounter, tobacco use is assessed. And with that assessment, we can now incorporate tobacco use treatment into our clinical encounters. In 2004, Mike Fiore led the first subcommittee on tobacco cessation, and it led to the establishment of the National Tobacco Quit Line. This tobacco quit line offers free counseling to all people who smoke in every single state. And then in 2008, he chaired the committee to publish the first clinical practice guideline on treating tobacco use and dependence. This is still the gold standard of what we use to treat tobacco dependence. So let's now move to pharmacotherapy. I'm going to go over the 7 medications that are available. And while this pharmacotherapy is about smoking cessation, we can also use those same therapies when we think about e-cigarettes, although the FDA guidelines are for pharmacotherapy for smoking. So the first category of treatment are nicotine replacement therapies. There are 5 different nicotine replacement therapies. I like to show my patients this slide whenever I talk to them about their nicotine use. When you look on the left, Marlboro Red, the amount of nicotine that's delivered to the user is about 1 to 3 milligrams, along with 7,000 chemicals that can harm them, including causing cancer. On the right-hand side, I show the short-acting nicotine replacement therapies that are available over the counter. The nicotine lozenge that's available in 2 and 4 milligrams, and nicotine gum that's also available in 2 and 4 milligrams. The approximate amount of nicotine that's delivered with these products is exactly the same as that's delivered by tobacco products without the harm. And so this is what I tell my patients: what your brain wants is the nicotine and not all the chemicals that's delivered with it. The nicotine patch is the long medication, the controller medication that we use. It peaks at about 2 hours after application and provides the longest and most constant rate of delivery. The FDA recommends duration of 8 to 10 weeks and to use it in a tapering dose. The recommendations are that if someone smokes more than 10 cigarettes a day, to use the highest available patch concentration, which is 21 milligrams, and if someone smokes less than 10 cigarettes, to use the 14 milligrams. In clinical practice, instead of using a tapering dose, studies have shown that just using consistent medication is as effective as the taper. So the way I use it is, if I'm using the patch and somebody is on the 21 milligrams and is not smoking, but is still craving cigarettes, I don't lower it until those cravings have subsided. In addition, combination treatment with this long-acting controller, as well as the available as-needed short-acting, produces greater efficacy in smoking cessation than just using the patch alone. The other 2 medications that are available over the counter are the nicotine lozenges and the nicotine gum. These levels, once you use the gum or the lozenge, levels peak at about 20 minutes. And so it's really important when talking to your patients to manage expectations. When someone smokes a cigarette, the nicotine reaches their brain in 10 seconds. And so when they are using these products, although, as I showed you on a previous slide, it delivers the same amount of nicotine, it takes much longer to reach the brain and produce the effects. And so when you're counseling patients, it's important to let them know to use the gum or lozenge and know that it will take time for it to work. The other important clinical consideration is, regardless of how many cigarettes a patient is smoking, I ask them, how soon after waking up in the morning do you smoke a cigarette? If they only smoke 5 cigarettes a day, but their first cigarette is within 30 minutes of waking, I recommend the higher dose of the nicotine gum or lozenge. And the third clinical consideration is to make sure that they're using these medications appropriately. The gum and the lozenge is not used similar to sucking on a candy or chewing a piece of gum. The way it works is, once you administer the gum, they need to chew it until a peppery taste is released. That peppery taste is nicotine. And then they need to park it in their buccal mucosa. That's how nicotine is absorbed. If they just chew it like a regular piece of gum or just suck on a candy, they will just get GI distress. So one piece of gum or lozenge should last about 20 to 40 minutes. And once they have it parked and the peppery taste goes away, they should start chewing it again and park it on the other side until there is no longer a peppery sensation. The other 2 medications in the class of nicotine replacement therapy is the nicotine inhaler and nicotine nasal spray. Both of these are only available by prescription. And as you can see, the peak levels are much shorter, at 5 to 10 minutes instead of the 20 minutes for the gum or the lozenge. Both of these medications are most effective when used along with the nicotine patch. Unfortunately, the nicotine inhaler is not available at the present time, but we're hoping that in the future this will become available. There are 2 other medications, both available by prescription. The first is bupropion. It's unclear how bupropion works in smoking cessation, but it's likely by its mechanism of action of being a reuptake inhibitor of dopamine and or norepinephrine. When people are on bupropion, more dopamine is available, and dopamine is one of the mechanisms of how nicotine acts to increase dopamine levels. So a couple of important clinical considerations with bupropion is that treatment is started at least 1 to 2 weeks prior to quit date. And duration, again, is by the FDA is to use it for 7 to 12 weeks. It's contraindicated in seizure disorder and in people who use alcohol, who have alcohol use disorder because of the increased risk of seizures when on these medications. Studies, again, similar to the other medications, have shown that combination therapy, so nicotine replacement therapy with bupropion, is more effective than using either product alone. Importantly, in 2016, the box warning for serious mental health side effects from drug label was removed. And the last medication is varenicline. Varenicline works both as a partial agonist and antagonist to the nicotinic acetylcholine receptor. So by working as a partial agonist, it helps with withdrawal symptoms, and by acting as an antagonist, it prevents nicotine from binding to the receptors. So when people smoke and they're on varenicline, they stop getting the pleasure from the cigarette, and eventually they often have a decrease in cigarette use while on this medication. So varenicline, again, the most important clinical consideration is that the box warning for serious mental health side effect was removed from the drug label in 2016. And this was following a large clinical trial called the EAGLES trial that included 8,000 participants. 4,000 participants had psychiatric illness and 4,000 patients did not. This study compared placebo, varenicline, nicotine patch, and bupropion. And while all 3 medications were more effective than placebo, varenicline was the most effective. Serious side effects were the same in patients who had psychiatric disease and did not. And importantly, this medication can be used with renal disease, including patients who are on hemodialysis, but the dose needs to be decreased. One of the most common side effects is nausea and insomnia. For nausea, drinking lots of water and telling your patients to take this medication with food can prevent those symptoms. So those are the medications we have. And so I want to next move to a clinical guideline that we conducted to answer the questions of practical considerations. These included, what is the optimal controller medication when initiating treatment? And so in 2020, I was a part of a panel through the American Thoracic Society that produced a clinical guideline that assessed this question. We looked at 14 randomized controlled trials that directly compare the efficacy of varenicline to nicotine patch, and the results showed that varenicline increased 7-day point prevalence compared to the patch. There are 7 randomized controlled trials that compared varenicline to bupropion, and again, varenicline was shown to increase 7-day point prevalence at 6 months. The other clinical considerations that we wanted to answer through this guideline is, what about people who are not ready to stop smoking? Should clinicians begin pharmacotherapy? Should clinicians begin pharmacotherapy in patients with psychiatric disease? And what is the optimal duration for these medications? To answer these questions, we looked at 4 randomized controlled trials that address the efficacy of initiating treatment in people who were unready to abstain. The studies that we looked at showed that varenicline increased abstinence compared to waiting for affirmation. There were 2 randomized control trials that compared varenicline to nicotine patients in those with mental illness. Varenicline also increased abstinence at 6 months. And finally, we looked at 8 randomized control trials that addressed the efficacy of extended duration treatment. So on those previous slides, I showed that the FDA recommendation doses is up to 12 weeks. These trials suggested that extended duration therapy probably increased abstinence at 1-year follow-up. So based on these studies, we recommended that when initiating pharmacotherapy to treat tobacco dependence, we should strongly consider initiating treatment with varenicline and extending treatment beyond 3 months after their quit date. This includes patients with psychiatric disorders and also includes initiating treatment with individuals not ready to set a quit date. We know that counseling plus medication is more effective than either alone. Dr. Jessica Cook, a professor of medicine and a principal investigator, program of research is to understand the best treatments for people who are not motivated to stop smoking. This is critically important because only about 15 to 30% of people who smoke are ready to set a quit date within 30 days. She is about to launch a multi-site VA study that will look at varenicline-based interventions that include counseling approaches to increase quit attempts and long-term abstinence in veterans who are not ready to quit. In addition, the clinical guideline didn't answer other important questions about combination treatment, novel treatments, and patients who did not quit on the initial controller or who have relapsed on initial treatment. So I'm part of an ongoing clinical practice guideline, this time through the American College of Chest Physicians, to answer some of these questions. Here are a couple of studies that we are looking at. The first is cytosine, marketed as cytisinicline in the US. The mechanism of action of this medication is similar to varenicline. It's a low-cost pharmacological alternative to varenicline, and it's been available for years in Central and Eastern Europe, but not in the US. Studies have suggested that it might have a milder side effect profile than varenicline. And a meta-analysis found that cytosine was more effective than placebo and more effective than single-product NRT. A study by Nancy Ragati and colleagues was just published a couple weeks ago called the ORCA-3 trial that was conducted in the US. It looked at cytisinicline versus placebo and a novel dosing regimen of 3 milligrams 3 times per day, as opposed to what is used in Europe, which is 1.5 milligrams 6 times per day. They looked at 800 patients that were ready to set a quit date at 20 US clinical sites and found that with 12 weeks of cytisinicline, the abstinence rate was 20.5% versus 4% in placebo at weeks 9 through 24. Right now, the manufacturer of this medication is seeking FDA approval in the US, and we hope that in 2026, this medication will be available to add to our treatment regimens. The other studies that we are looking at to include in the guideline include this interesting study that looked at patients that were initially randomized to varenicline and combination NRT, and then for patients that did not stop smoking to look at what treatment regimens might improve abstinence. So in the first arm, about 250 patients were randomized to varenicline. 120 were non-abstinent at 6 weeks, and those patients were randomized to either an increased dose to 3 milligrams, which is not the standard level, to stay on 2 milligrams, or switch to combination NRT. You can see that the quit rates were 20% for those patients who had whose treatment was increased to 3 milligrams. In the other arm, people that were randomized initially to combination NRT with 21 milligrams of the patch and lozenge and were not abstinent were then randomized to varenicline an increase to 2 patches or to stay on the same 21 milligram patch for a longer duration. Those patients who were switched to varenicline or had an increase to 2 patches, so 42 milligrams of NRT patch, had a higher abstinence rate of 14% compared to 8% on those who stayed on the patch. So these are the type of studies that we will be looking at in the in our new clinical practice guideline that will be coming out. So we know that we have effective treatments, and how can we implement tobacco treatment into clinical practice? I'll go through 2 scenarios. One is in hospitalization, and the other is in the cancer setting. So this is work that I conducted at Boston Medical Center. As you can see, the smoking prevalence rate at BMC for people who are hospitalized is about 25% compared to the national rate of about 11.5%. Not surprising, because Boston Medical Center is the largest safety net hospital in New England. The majority of people who smoke and are admitted to the hospital are Medicaid insured, and many have substance use disorders and serious mental illness. Opt-out approaches are approaches where we offer treatment to all people who use tobacco, regardless of motivation or readiness to quit. So many of the studies that I have shown you are in people who are ready to stop smoking. When we look at opt-out approaches, we often see lower quit rates because we are including people regardless of that motivation. Studies using opt-out approaches have shown that when opt-out approaches are used in the hospital and treatment for tobacco dependence is continued for 30 days after discharge, have increased smoking abstinence 1 month after discharge, have reduced 30-day hospital readmissions, and have reduced healthcare costs. So we developed a EHR-based best practice advisory. So based on tobacco use being a vital sign, we first looked at how accurate is the smoking status in the EHR. And we showed that there was 98% accuracy of people who smoked and what was recorded in the chart. So based on that, we developed a best practice alert that said, patients currently use tobacco products, please place the following tobacco treatment consult order. And the only options were to order the consult, which then triggered a list of patients to a tobacco treatment consult service that offered bedside counseling, recommendations for pharmacotherapy while hospitalized, and linkage to outpatient treatment at discharge. The only way that you could choose any result other than order was to say, we'll place order later. At that time, the BPA would trigger every 8 hours until the patient was either discharged or a consult to the team was ordered. The results from that study showed that in patients that were seen by the tobacco treatment consult, represented by the black bar, compared to patients not seen by the tobacco treatment consult service, and this was due to time constraints and resource constraints. There was higher inpatient NRT during hospitalization, higher rates of NRT prescribed at discharge, and increased 6-month quit rates. Importantly, we looked at the sustainability of the program 5 years after inception. And you can see, regardless of whether throughout the years from 2017 to 2022, if a patient was seen by the tobacco treatment service, there was higher rates of combination NRT, both during the inpatient and at discharge. You can also see in the hatch bars that there was a culture change, that even if we weren't, even if the tobacco treatment consult team was not able to see patients, there was a gradual increase in patients receiving NRT, even if they weren't seen. So the main takeaways from this is that opt-out EHR-based tobacco treatment consult service is feasible, effective, and sustainable at a safety net hospital. I am currently in collaboration with Dr. Quinn Pack at UMass testing if this intervention in a randomized controlled trial is effective and cost-effective. In addition, I'm co-chairing a clinical practice guideline through the American College of Chest Physicians on how best to initiate and continue tobacco treatment in people who are hospitalized. The next clinical setting that I want to briefly talk about is the cancer setting. We know that quitting smoking upon a cancer diagnosis increases the effectiveness of cancer treatments, decreases side effects of cancer treatment, decreases recurrence of new primary cancers, and decreases all-cause and cancer mortality. The NCI thus urges all cancer centers to improve their rates of tobacco treatment. The NCI Cancer Center Cessation Initiative, called C3I, was a study that looked at 52 cancer centers with the goal of increasing these NCI-designated cancer centers to promote smoking cessation among cancer patients. The funded centers were charged with using population-based approaches to screen and offer treatment. The UW Carbone Cancer Center and our center, UW C3, was the coordinating center for this initiative that collected the reach and effectiveness data and supported EHR integration and workflows. As you can see, since its inception of since 2018, over 100,000 patients have received tobacco treatment through this program. And you can also see that there has been equity of reach by race and ethnicity. In looking at this data, the authors found that there was higher effectiveness when EHR referrals were used. This is a study that was just published a couple months ago, looking at treating tobacco use in the lung cancer screening setting. So lung cancer screening is recommended for patients who are 50 to 80 and currently have a 20-pack year smoking history. They can either be currently smoking or had stopped smoking within 15 years. So this study looked at the efficacy of 3 treatment delivery strategies with increasing levels of integration and intensity. Patients were randomized to receive quitline referral for counseling and 12 weeks of NRT. They were randomized to quitline referral for counseling and then having a lung cancer screening clinician prescribe medications, either bupropion, varenicline, or NRT, or a fully integrated care where a tobacco treatment specialist did the counseling and also offered medication. The best quit rates were seen in intensive treatment of 37% of people having 3-month quit rate abstinence and 32% having abstinence at 6 months. But you can also see that in patients that were referred for this free service, so for free quitline, and had the NRT prescribed by the quitline, also had high quit rates of 20%. To put this in context, people who do not receive counseling or medication, the quit rates are usually between 5 to 8%. So this study really shows that if resources are available, intensive treatment provides the best option. But for those centers that may have lower resources, direct quitline referral can support cessation. And so the summary from this is that integrating tobacco treatment in clinical settings, the characteristics of successful programs are embedding tobacco treatment into the health system, incorporating reminders into practice systems, and proactively offering treatment regardless of motivation to quit. So here is the best practice alert that we used in our setting, but similar best practice alerts can be used for referral to the quit line, for order sets for pharmacotherapy. And so I encourage everyone to really think about tobacco treatment in the clinical setting. As clinicians, we should all be talking to our patients about smoking and about the benefits and efficacy of medication, but also our health system should be integrating tobacco treatment into these clinical scenarios. So Opportunities and next steps. As I just mentioned, the pilot RCT of looking at different intensity treatment to help people stop smoking. And Doctors Danielle McCarty, Kay, and Michael Fiore are planning a new clinical program in collaboration with DUW Carbone Cancer Center and UW Health to apply lessons learned from C3I to enhance tobacco treatment in lung cancer care. So moving on, there's also many opportunities to expand research to other UW clinical programs. So Dr. Adrienne Johnson, her program of research is to look at motivating change in aging people. This is critically important because although only about 8.9% or so of aging adults smoke, there has not been that same decrease in smoking rates among this population. Many people think that they are not, that they're not interested in smoking, but in fact, studies have shown that they are, and treatment is effective in this age group. So looking at this population and looking at the lung cancer screening, which is 50 to 80 years old, applying lessons learned from her program of research has the ability to impact lung cancer screening, smoking cessation and lung cancer screening programs. And this is important because about 50% of individuals who are screened for lung cancer are continuing to smoke. Finally, another opportunity is with the advanced treatment options available at for COPD. So UW offers lung volume reduction as well as transplant for patients with COPD, and of course, transplant for other clinical conditions. But in order to be candidates for these programs, people have to have been abstinent from tobacco use for 6 months. So there's really an opportunity to help these individuals stop smoking so that they can be available for such programs. So I'm briefly going to talk about tailored intervention. So I had talked about how decreasing initiatives have led to a decrease in smoking prevalence from about 44% in 1964 to 11% in 2021. But if you take a deeper dive, you can also see that smoking prevalence has become segmented. So those whose household incomes are less than 35,000, those who have mental illness, the LGBTQ plus population, and those that are less educated have very high smoking rates. And so this graph shows that in patients without substance use disorder, we're seeing that gradual decrease in trend of tobacco use. But if you have substance use disorder, the smoking rates are as high as 60%, especially in patients with opioid use disorder, where smoking rates can be as high as 80 to 90%. So Jen Betts, Dr. Jen Betts, an advanced addiction fellow who is working under the mentorship of Dr. Jessica Cook, is interested, and her research is looking at reducing tobacco-related disparities in people with substance use disorder. In addition, Dr. Danielle McCarthy, through a UG3-UH3 program, is looking at strategies to connect participants at Salvation Army service centers to the quit line. So we're excited to look at those results from these studies. One particular disparity that I want to call attention to is the high burden of lung cancer among Black adults. So the smoking patterns in Black adults is about the same nationally between Black and white adults of about 11.5%. There are state-specific disparities, Wisconsin being one of them, and that's what this graph looks at on the left. You can see in purple is the smoking prevalence in whites compared to the smoking prevalence of Blacks in yellow. And while this disparity is decreasing in 2023, about 16% of Black people smoke compared to the national prevalence rate of 11.5% in whites. So the state-specific disparities are particularly concerning. There's other states that also have this disparity. In addition, Black adults have higher lung cancer incidence and worse survival rates compared to white adults. And this is despite the facts that Black adults who smoke often smoke non-daily and fewer cigarettes per day and have started smoking at later ages than whites. And so I think it's important when we treat for tobacco use that we help all people who smoke, including those who smoke intermittently or fewer cigarettes per day. So this is a study that I'm particularly excited. We're about to launch this in a couple of weeks in June. It's a PCORI-funded trial with myself and Dr. Megan Piper in 5 states. And we'll be looking at a comparative effectiveness trial of 3 different interventions, each with increasing intensity and tailoring, including the last group that will include a financial incentive for attending counseling, and we'll look at long-term smoking cessation rates. So in the last 10 minutes or so, I'm going to switch to smoking cessation transitions. So by this, we're really looking at what are the harm reduction approaches of switching from cigarettes to e-cigarettes. So to start, what is the data on the effectiveness of e-cigarettes on smoking cessation? So there's been meta-analyses that have showed that in randomized controlled trials, e-cigarettes as a therapeutic intervention is associated with increased smoking cessation. In addition, a clinical trial in England, as well as a Cochrane review that was just published in 2025, which is a living document because research is accumulating quite rapidly in this area, but shows that electronic cigarettes work better than nicotine replacement therapy in promoting abstinence at the 6-month mark. However, in the US, e-cigarettes are not approved by the FDA as a medical product for smoking cessation. And because e-cigarettes are produced by Big Tobacco, it is likely that they won't be. And so when we look at e-cigarettes, I like to look at it as a smoking cessation transition. So in people who smoke cigarettes, we need to look at what their end state will be. If they use e-cigarettes and continue to use e-cigarettes or transition to no use, there may be benefit. However, in patients who are using cigarettes, who are using e-cigarettes and become dual users, there might be increased harm. And so, importantly, continued dual use is common. About 25% of people who use e-cigarettes become dual users. And this is a trend that's concerning because dual use may be more harmful than using cigarettes alone. And so this is a study that just came out a couple weeks ago that looked at cigarette only and dual use. This is from a longitudinal data from the All of Us program. And it showed that that was followed for 4 years. In people who used cigarettes or dual use, there was a strong association with COPD. And although the point prevalence was higher with dual use at the 4-year mark, the confidence intervals cross. So we'll see what this looks like as the data goes out 5 and 10 years. But some concern that dual use may have an increased incidence of COPD. This study is a case control study that looked at 5,000 patients with lung cancer and 30,000 patients without cancer. And concerningly, there was a 4-fold higher risk of lung cancer among those who combined vaping with smoking cigarettes compared to those who only smoked. And this finding was consistent in both men and women. So a trial that has just started in 2024 is aiming to look at what are the most effective interventions to helping dual users stop smoking cigarettes. And it's looking at pharmacotherapy, counseling intensity, and approach that focuses on cessation of both products versus cessation of smoking using ENDS as a harm reduction approach. On the other hand, if people transition to e-cigarette use only, there may be reduced harm. There's studies that suggest that there's reduced exposure to polycyclic aromatic hydrocarbons and volatile organic compounds when you switch from cigarettes to e-cigarette use only. However, complete switching to e-cigarettes is less common despite initial intentions to quit smoking, and the long-term health effects are unknown. So when patients are using e-cigarettes as a means to stop smoking, it's important to really talk to them about eventual cessation of all tobacco products. This is especially important because continued use of e-cigarettes following smoking cessation may heighten the risk of relapse. And this is just one of those studies from the PATH database. The PATH studies were initiated in 2013 through NIH and FDA as an annual longitudinal survey, and has the most comprehensive collection of tobacco-related questions. And it shows that among people with no underlying lung disease, switching completely from combustible tobacco to e-cigarettes may lower the risk of respiratory disease. But that trend was the same, that there was only a small percentage of users who completely switched to e-cigarettes. This is a study that I was a part of that showed similar findings. We looked at people who had baseline cough and wheeze using the PATH database. And if you were to transition to exclusive e-cigarette use, there was resolution of wheeze. However, with dual use, there was a 15% decrease rate of symptom resolution. So again, important to counsel patients on the risk of dual use if they are choosing e-cigarettes as a way to transition off smoking, and to also eventually look at complete e-cigarette cessation. This is an interesting study looking at that's about to kick off in a couple of weeks, of looking at smoking cessation transitions instead of cigarettes, moving to nicotine pouches, which may be helpful in helping people switch from tobacco products to pouches. Okay. So the last group of studies that I know we have just a couple minutes left, is looking at e-cigarettes in people who are naive to tobacco products. And this is particularly important when we talk about switching e-cigarettes for people who smoke. This is very different from our adolescents and young people who have never used tobacco products. And we know that e-cigarettes are harmful in this population. And this is, again, using the longitudinal database from the PATH studies that show e-cigarette use, cigarettes, and dual use increases the risk of bronchitis, pneumonia, and chronic cough in youth. Dual use, that same pattern, is associated with the highest risk. And in people with underlying asthma, there's the greatest concern. A study just came out a couple weeks ago on varenicline for nicotine vaping cessation that showed that varenicline plus counseling and tech support increased abstinence rate in youth. Brian Williams, Dr. Williams is, through his KO8, is looking at predictors of quit attempts and successful quitting, and looking at a clinical trial that's going to look at enhancements to a text messaging program that has been shown to help young people quit vaping. So we're excited to see the results of that study. And finally, we are part of a guideline that will be published in a couple of months of how to treat nicotine dependence in adolescents under 18 years of age. Okay. The last study that I wanted to point out, I know our time is short, is the Vape Check study. This is looking at in patients who have who do not smoke and are using vape products. We are looking at how do biomarker changes related to vaping affect cardiometabolic health. This is really important. All of the studies that I've shown you have been survey studies, And survey studies are only, they talk about what the current use is in the past 30 days. This will be a detailed assessment of the different products that are used, the heaviness, the vaping patterns, and so it'll give us a lot of important information. And I think I'm going to end there. I want to just end with a concerning trend that we're seeing in tobacco and cannabis co-use. About 50% of adults who use tobacco products are also using cannabis products. We see in the cancer population that people who are diagnosed with cancers who all are more likely, about 70%, use cigarettes. And concerningly, they use inhaled products. And so we do not know the effects of co-use of tobacco and cannabis use. We know that people who use cannabis are less likely to succeed in tobacco cessation. And we also know that this is complex. So the effects of tobacco and cannabis use on lung health is unknown. So we just completed a research policy statement to kind of spur interest in this area. We are very concerned that of the increasing co-use of this substance. Dr. Jesse Kay just held was part of a committee that held a cannabis research conference, and he led a panel discussion on looking at the health and medicine effects. And, using approaches, perhaps AI-driven co-use screening like this study that Marlon Munt and Dr. Afshar did, can be very important to try to understand who's using these products and then to look at the screening and clinical effects. So I want to end with thanking our incredible center. Our outreach team, led by Karen Connor, makes sure that all of this evidence-based research reaches the health systems and provides training and technical assistance. The Quit Line is managed by Kate Kabinski through UW-CTRI. And finally, all the people behind the scenes that are doing the work, our health counselors, our data management team, our researchers, and our admin team. So I want to give a huge thanks to everyone.
Thank you, Dr. Kathuria, for an incredibly thorough and important presentation. For those of you who ask questions, we're going to follow up with those responses offline. And I want to thank all of you who have attended our session today. Thank you, Dr. Kathuria, and welcome to the University of Wisconsin.